Paso County Board of Health to order. I'm going to start off with a member roll call, and I'll just go around the tables here. We'll start with an echo. Is there something we could do about that? Okay. I'm going to start with Councilman Dave Donaldson.
Here.
And Dr. Richard Vu.
Here.
Commissioner Gonzalez.
Here.
And General Briggs.
Here.
And the my Vice Chair, Doris Ralston. Here. Okay, and then online, I believe we have Dr. Chan.
Yes, here.
Okay, and then Commissioner Bremer.
Present online.
Okay, great. And then I understand that Mayor Habener is sick today and not going to be able to join us. Next thing we're going to do is approve the agenda. We'll need a motion and a second to approve the agenda.
I'll move to approve the agenda for the 27th of March, 2024 Board of Health meeting.
Second, Dave Donaldson.
Okay, thank you, General Briggs and Councilman Donaldson. All in favor of approving the agenda, let it be known by saying aye.
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 Any
Aye.
opposed? And hearing no opposed, that passes. And we'll move on to Board of Health comments. Look around the room and see if we have anyone who wants comments. General Briggs does.
I have two things. The first is the House is considering a bill concerning what they're euphemistically calling overdose prevention sites or overdose prevention centers. I'm going to back up from this just slightly. And are more commonly known as safe injection sites. As a nonprofit CEO dealing with addiction and recovery and active users of drugs, particularly the dangerous idea of fentanyl, I believe personally and as a board we should take a position on this because it will be addressed at the State Board of Health, I'm sure, as well. And I would propose that we would be in opposition to the bill 1124. Specifically, the bill states that municipalities will be given the opportunity to have safe injection sites in their municipalities. What this will create is a incentive for those who are struggling with addiction to continue with that addiction, as opposed to seek the variety of services available to them in a very difficult process, which I fully recognize. The second is that it will create a bit of a competition between municipalities, because I believe if it were to pass, municipalities will all wait until one of the municipalities around them chooses to have a safe injection site. All the other municipalities will then probably say, no, we're not going to do this. And what that will do is overwhelm that single municipality with potential users. It's an unexecutable bill. And so I would propose that we do not incentivize the use of illegal drugs for the health benefit of the community.
Thank you, General Briggs. You said you had two things?
Yes, the second one is I read the article this week about mental health with Director Whelan and the mayor's office. And first of all, I appreciate that very much. And I wanted to comment on how much I appreciate the cooperation. But I was interested in the dashboard. And I wonder if we're going to hear about the dashboard. Oh, good. Okay. Disregard everything after good morning. Thank you.
And Doris.
So General Briggs, is there a dollar amount attached to those sites that, are they going to be allocating resources for those?
So the longitudinal information, which really comes from the British Columbia, particularly in Vancouver, over 20 years, is that a site will cost somewhere between $2 to $4 million a year, and that has to do a lot with the medical part of people responding to the overdoses. So it's a very expensive proposition. You can't spend your way out of this. We hear that often. And it incentivizes an activity that is destructive.
Thank you.
Commissioner Gonzalez.
Thank you, Mr. Chair. And so I support Jack's proposal here, and the mechanisms of doing that, but I support his opposition to that. And I'll add a second reason. As General Briggs mentioned, it's an opt-in, but if you recall, needle exchanges were opt-ins, and this community has rejected them, and luckily that has not yet come back again. But the state decided to take it from an opt-in to removing the options for the local boards of health to deny this. And so when they say they're going to make it an opt-in option only, well, guess what? I don't believe the state, because they took that away from boards of health on a separate but similar issue that has also proven to not been supported, because we're told, well, our community is the only one who doesn't do it. Well, look at the disaster that's happening in Denver. So when they point to examples, and the Canada example has been proven to not been working as the media misportrays. So I appreciate that, and I will be supporting anything that we can do to support that opposal. Thank you.
Okay, Councilman Donaldson.
Just for everyone's information, the city of Colorado Springs has already taken an opposed position on that bill up at the State House, and I don't know if the county has, but I won't be surprised if others have also. So I don't know if this board can take an opposed position. I don't know if we have a lobbyist that can register that. I think not. So we'd have to do it some different way, but just for information, the city has taken an opposed position.
May I? I'm sorry.
Yes.
May it be something that we could put onto the next agenda and then vote on a resolution?
I'm looking at our attorney. Can we do that?
I believe so. I could get with Director Whelan and we can talk. We can discuss how to get that agendized.
Okay.
Yes, for
Can you guys hear me?
legislation in the past where the Board of Health supports it or opposes it, there have been resolutions presented for the Board of Health's vote.
And
All
I'm
right, there
happy
may-
to help craft or work with the attorney and the director if needed.
Okay. And there may be additional comments on this subject. I don't know. I think Commissioner Bremer also has comments.
Just a couple of quick questions. Regarding a resolution, I would also love to see one come before this board. I think the timeliness is an issue. And I mean, as we all know, the legislative session moves very quickly. And so to have to not have this in front of us before a month probably means that it would maybe not get seen by our legislators if this board takes a position. The other question I had was, does anybody have a bill number? And I interpreted Doris's question as asking whether there was a specific
Excuse me, Cami.
fiscal note attached to this.
Cami, I'm sorry. I'm going to have to ask you to hold on just a minute, and we're going to try to work out some technical things and have you repeat that. We missed the last half of that. I heard the part about the timeliness of a resolution, but then after that, you kind of faded away. So hang on just one moment. Okay, give it a try now, Cami.
Okay. I think the other thing I was asking about was a bill number and potentially, I interpreted Doris's question to be asking about whether a fiscal note had been attached to this bill in particular.
If there's any financial attachment to the bill, is that the question?
Correct. And a bill number.
Do you know the bill number?
I believe it's 1124, but I can research that. And also, I think the fiscal note, I think was still being debated because there were amendments that were being proposed. So I think we would need to probably do a little bit of research to figure out the specifics on that.
And I agree with Cammie that timeliness is everything on this because our state legislature only meets for a short period of time. And if we're going to do something, might have to do it outside of the meeting. This way we can do that.
Okay. I'm going to get one more comment from Dr. Chan. I think she has comments also.
Yes, thank you. Cammie's comment does bring up a question in my mind, and that is, does anybody know when the bill is coming in front of the legislature for a vote?
So the bill was in committee 2 weeks ago, but I'll have to go back and look and see if it and see if they actually brought it to debate.
Okay. The other thing I'd like to say is that I am generally in support of General Briggs's position and the position of other members on the board. I do understand that there's a gray area and probably a thin line between enabling addictive behaviors and harm reduction. I think that with harm reduction, we really do need to know a little bit more of the data and the information on how this proposed solution was arrived at. And I understand, I'm not an expert on addiction, but I do understand from looking at some of the academic articles that there's conflicting data. On the one hand, safe injection sites may prevent deaths in a clinical sense, but we're a public health board. And so what we're interested in is population health. And from that perspective, I understand that there hasn't been any significant harm reduction because what happens is that right outside of these injection sites is where there tends to be an uptick in the number of drug purchase transactions. And then for people who are purchasing their drugs at the site or right outside of the site, there often tends to be an uptick in use right outside of the sites, and therefore an uptick in overdose events. So I think that without definitive information, our position should be that first, we do no harm. I do find it interesting that there may be disparities in attractiveness to the community that is struggling with addiction. And I will say that if one municipality decides to provide the safe injection sites and becomes an attractant for that type of behavior, it is likely to serve actually as a counterfactual to the communities that don't do so. But at this point, I don't have knowledge that would allow me to say that for certain this is a harm reduction activity.
Just my age and my dyslexia, it's House Bill 1028. Sorry, it's 24-1028. So that's my dyslexia. It's in its The House has had a second reading laid over, and there have been no amendments, but I don't see a fiscal note attached.
All right, just with the discussion this morning, I've heard comments in support of General Briggs's recommendation from Commissioner Bremer, from Dr. Chan, from Councilman Donaldson, from Commissioner Gonzalez, from Doris, and I would support that myself. Dr. Vu?
I also support opposition of the bill.
Okay, so for members present, we have a unanimous support of a resolution. I'm also concerned with timeliness, so Kenny, if you can work with Director Whelan, and if that's something that we can craft and put out over email to the board and have board approval that way, we can read it into the minutes at the next meeting, but maybe we can pass the resolution prior.
Sir, I'll speak with Director Whelan about it. I think that you'll need a notice public meeting to approve a resolution,
Okay.
though. But we can probably work something out to be timely.
Okay. Well, whatever we need, whatever we can do, we would certainly be in support of doing that. General Briggs, thank you for bringing that to the attention of the board. We appreciate it. And thank you for, you seem to always keep on top of what the legislature is doing, and I really appreciate that.
If I could just remember the numbers, they get confused. I'm sorry about that.
Okay, any other board comments? Seeing none, we'll move on to the approval of the minutes. I'll need a motion and a second to approve the minutes.
So moved.
Second?
Thank you, Doris and Commissioner Gonzalez. All in favor of approving the minutes, let it be known by saying aye.
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 Okay. Any opposed? And hearing none, that passes unanimously. Okay, I'm looking over at Lee. Do we have any public comment for things not on the agenda? No, we don't? No. Looks like we do. Come on forward, yeah. Just give us your name and then what you'd like to talk about.
Great.
We know your name, but
My name is Dave Lineover. I'm councilman at large for the Colorado Springs, and I know most of you. And I wanted to express with some excitement that tomorrow at 10:30, we will be, the city will be making a public announcement about launching the 1,000 neighborhood gatherings across the city. And this is an initiative is about connecting neighbors to one another to address social isolation and loneliness. And I kind of look to the county to see if they would like to be a larger piece of this. I don't think it's publicly, or this group has publicly said that they'd like to find a way to participate. Susan's been involved in a lot of the conversations and stuff like that, but I've never brought it to this committee about that. So we're pretty excited. So the 28th tomorrow, we're gonna talk about it. The launch will be the weekend of May 17th and 18th, and it will run through the summer. And then we'll have a concluding event in September on Good Neighbor Weekend, I believe is what it is. And so that will be an initiative that we're gonna run throughout the city. And we're going to ask community leaders to kind of think about their own neighborhoods and how they can bring their community together and really prevent and address isolation and loneliness, which is, as you all know, a big component of some of the challenges with mental health and suicide.
okay, and tell me again what it was called, the 1,000 neighborhood
Gatherings.
gathering.
Yes, that's the official title, will be 1,000 neighborhood gatherings. Initially, it was suggested to be 1,000 block parties, but because block parties are difficult to manage, we wanted to encourage people to think of other type of events. And because parties have a connotation about alcohol and drugs, we wanted to get away from that connotation. So that's how we came up with 1,000 neighborhood gatherings.
Okay.
So,
Well, I certainly appreciate you bringing that to our attention. Thank you. It's something that my wife and I do in our neighborhood every year, so
yes.
it's not a foreign concept. We want to do it for those very same reasons, to make sure everybody in our general area knows that there's someone that cares about them. So
Yeah, I
Thank
think
you for
it's
that.
just more of, there are already those going on, and we know that they are extremely helpful to communities, but not every community is doing it. I mean, even myself and my wife had been talking about it for 20 years, and we just never did it. And so this is just to give kind of the help to kind of do that. We decided to do a Christmas cookie exchange. And we invited our neighbors, and not knowing if we'd get 2 or 4 people show up. Well, 27 showed up for a 3-hour event, and it lasted 5 hours. And so, it's that kind of thing that we want to try to generate. And now we have, more connection within our neighborhood than we've ever have had before. And so it's that, we want to activate the community. We certainly can't hire enough professionals to address our mental health crisis. So what are some other means that are just easy buttons per se to really get the community aware of this and just activate it? And we have several partners. We'll be partnering with Cuz I Love You and Kono are our key partners. NAMI is going to be a part of it, and also UCCS, Chip Benight. With the GRIT program, we're looking at trying to adopt his goal of having 25,000 GRIT coaches by the end of the year. So that's his aggressive goal. I don't know how he's going to achieve that, but he said that last month, and so we'll see if we can maybe come along and support that through this effort too. So there'll be a component of that, encouraging people to consider taking the GRIT training. So.
Well, again, thank you, Councilman, for
welcome.
bringing that to our attention. And I know that Director Whelan has something to comment.
Yes, thank you, Mr. Laneweber. There's so many different pieces to the collaboration, and there have been connections with El Paso County in addition to Public Health with Commissioner Bremer, and we're also going to be doing some demos as it relates to the behavioral health platform. We're not going to call it a behavioral health platform. We're so early in the phases as it relates to tightening up and working with our communication and marketing folks as it relates to even launching. So with one of the first efforts that is launching is the neighborhood gatherings. And I wanted to emphasize that it is framed around building resilience and working very closely with Dr. Benight and the Lyda Hill Center and Human Resilience, because I think that's very important when we talk about this and addressing the Surgeon General's report about isolation and how concerning that is, because when you say party, I have concerns. And I know that when that was presented, that didn't get to what we were trying to accomplish. And so I'm very happy to hear that the name has changed, because it has been very intentional with the National Alliance on Mental Illness, with Dr. Benight. And so it will be supported through these efforts and giving the tips and tools as it relates to how do you build resilience in communities. And so I'm really excited about it, and what we're waiting for is the, where do you register? And then we certainly will be helping out to get the word out. And I've already been asked from the article in the Gazette, when is this happening? And I said it's coming, and I think likely on Thursday. And so there are people that are interested, and especially like some of our formal employees that have actually retired. They're wanting to do this. But with that article, Mrs. Mobilati and I had the challenge of being asked to give an interview, but not being ready to share all of the details, nor are all of the details ready with the efforts. So that's the reason why some of the details are not provided. But
Well,
I'm happy to help with the neighborhood gatherings.
Yeah, so tomorrow the website will be launched tomorrow. So all the details will be up and going, and I just wanted to make you aware of this program. I think it's a pretty exciting effort and something it's kind of dear to me, so I'm really excited about it and just really glad to share it and some of the things that the city is kind of working on, so. All right.
Again, we appreciate it. Thank you very much. And, just on behalf of our board, I think that anything that we can do to help people gain a sense of community and feel as though that they're involved and they have that connectedness is something that we would be supportive.
Great, thank you very much.
Okay, and I believe that brings us to number 5, Susan, the finance and budget.
Good morning. I'm Sarah Kinney, El Paso County Financial Services and Budget Supervisor for Public Health. Can we go to the next slide, please? All right, so as promised, we have our 2023 year-end financial position. And so I'm going to step you down through this financial presentation in sections. First, I'd like to talk a little bit about our revenue. As you know, much of our revenue in public health comes from our grant funding. And so as you can see, we have a number of budgeted items there, specifically ARPA and our ELC and program-specific grants, where we did not have specific expenditures for those grants that we were able to bill against towards that budgeted amount. That sometimes happens on these grants because those grants are very restricted or very specific, things like COVID or ARPA, or for example, the ELC grant, which ended in July of 2023. So we had the opportunity to budget to those total amounts, but we only had expenditures in the amounts that you see in that center column. And that's why you're seeing those larger variances over there in the right-hand column. Those are nothing to really be concerned about because we were able to bill for everything that we expended. And so that's not contributing to your variance that you see at the bottom in the net column. The other thing I wanted to mention is that the unused funds from ARPA are actually going to flow over into your 2024 budget. So we don't lose those 2024 grant funds. We were actually able to move them forward, and we'll be able to use those for the Public Health Agency in 2024. And I've included those as part of your OAB, which you approved at a previous board meeting. Okay, so stepping down on the revenue items, I'd like to bring your attention to licenses, fees, and permits. As you can see, our actual licenses, fees, and permits came in about $604,803 short of what we anticipated. This was largely due to the Environmental Services Business Unit. We had projected post-COVID some economic growth in the restaurant, retail foods licenses. And as you know, from the October board meeting, we weren't necessarily recovering all our costs from those license fees, and we had worked with the board to actually increase our fees so that we could recover our costs. As we went through the year in 2023, you may have been aware that interest rates actually increased, and that slowed the amount of folks that came to the board, or excuse me, came to the agency and requested new restaurant licenses. So we did not see the amount of customers that we had anticipated, so we didn't have that revenue come in that we had anticipated. And that's really what's driving our net impact down at the bottom that you see in the variance. So as we step through that revenue, all of our expenditures that we had for the grants are covered, but it's that 604,803 that's really driving our net impact down at the bottom. Now, I don't anticipate that this will be a problem in 2024. And when we get to the status for 2024, I can talk a little bit about how we're doing on licenses and fees. I think anyone in your position might say, well, Sarah, how are we going to be doing going forward? Are you watching these fees as they're coming in? Are we being too optimistic? I think that we had healthy growth in our population in El Paso County. I took a look at the census numbers. We previously had 1.5% population growth during COVID. That number nearly doubled in El Paso County to 3% population growth estimated. So I think what's happening is we had a delay in that demand for restaurant services, largely driven by the increase in those interest rates, because now we are seeing some of those demand for restaurant licenses come in. And in fact, you'll see in the February report that our licenses and fees have popped up. It just happened a bit later than we thought. All right, the other thing I'd like to mention to you is we did anticipate that we would go into the fund and reserve balance by $225,745. So that $635,711 is around $400K more than we had anticipated. If we'll go to the next slide. This kind of shows every business unit and approximately their contributions to the reserve fund use. These other areas, laboratory services, operations, health services, and tuberculosis program, these were normal variances that I would expect to see on a budget of your size. We already discussed the grant-specific revenue source limitations, but the main contributor really was environmental services. So you may be, oh,
I'm
yes,
sorry,
sir.
can you back that up?
Yes, sir.
again? Now, here I understood, I guess I'm just gonna ask, how do you get to that 445.9 number for environmental services? What all is involved there?
Yes, sir. So we have a number of different elements in environmental services, body art, retail food licenses, a number of those elements that were presented to you in October, and I can provide the board a complete list of those. But when we assessed those, it was really the retail food licenses, the revenue that did not come in, that drove that 445 number.
Okay, that's a lot higher, I think, than I recall. I guess the last time that we talked, we were going to go into the reserve by about $200,000 and some, and now that's up to 600,000. Is that correct? To 635?
Yes, sir. 635, 711. So that is an increase of around 400,000. So there is a difference in terms of what had been previously approved by the board of the reserve fund use.
May I add, what I understand is when we were putting together the 2023 budget, we had anticipated around a 30% growth in retail food establishments, the brick and mortar ones, and we did not see that growth. Therefore, we weren't able to generate any revenue with that projection, and that's resulting in the over $400,000. And I will say that as a effort with an effort statewide, we are looking at the retail food establishment license fees, what our local board does not have any control over. That fee is set in state statute, and we are not able to recover our costs, and that has not been assessed probably for, it might be like 7 years or a decade as well. So that's an effort that is, I don't think that we'd probably ever get to a place in the near future that we would be able to 100% cover our costs with the retail food establishments, but there is progress that would be realized if everything goes well for the 2025 budget. But that's where I'm seeing the downfall is that we were seeing growth, and it was kind of counterintuitive during the pandemic that restaurants were increasing. We didn't see the decrease, and so we had estimated that it was about an aggressive estimate, about 30%. And there's other license fees in there, but the bulk of it, what I'm understanding, is a retail food establishment, which is the brick and mortar ones.
And the risk was if we didn't have appropriate trained staff and the restaurant growth due to population and those low interest rates had happened, we could have actually stifled that post-pandemic growth in the county and actually held back businesses because we wouldn't have been able to support services in a timely manner.
Go ahead.
Well, I understand what you're saying, but what about the other, I call them general funds that we get from the county? I would think that when we're budgeting, we look at some of those since we know that the fees aren't covering the cost of that particular area.
Yes, ma'am. So how the budget works is we have that set amount that we get from the county, and that was included in our total budget. This amount that we budgeted for environmental services was based on revenue we anticipated from customers. Since that revenue didn't come in, we didn't have that, and that other county budget was already accounted for elsewhere to be used in our agency budget for other items. And I can show you exactly where this would come from in the reserve fund to show you how we'll be sitting going forward. We're still in a very strong position. I'd like to.
Well, we got a couple more questions.
Oh, yes, sir.
I'll ask mine first. If we're not covering our expenditures, if our fees don't cover our expenditures in food service, how can we make that up with greater volume? Sounds like we're going the opposite direction if we have more volume.
Yes, sir. And that's why in June we did the analysis of the fees and came to the board in October. You are absolutely right. We won't make it up in volume if we don't get right with our cost allocation to our fees. And so we did come to you, and that was approved by the board. And so over time now, we'll be on a path to get right with our fees that we control.
But not with restaurants, not with food service, because we don't have any control over those fees. So we didn't adjust those in October. And so your statement earlier that our projections were based on more food service and growth in the restaurant industry, that's counterintuitive to me. It seems like that would take us in the opposite direction if we're not making up our fees.
Oh, for the October increases doesn't cover that restaurant
Well,
foods.
at any point moving forward, if the cost of doing business
Yes, sir, I understand.
the cost exceeds what we bring in, if we increase volume, that just takes us in a more negative direction. That's how I'm seeing things. I don't understand when you say that we didn't meet our expectation of restaurant growth. In a sense, I think, well, good, because if we had more restaurant growth, we would create a bigger gap.
Yeah, I was speaking more in terms of the growth of the fees overall, not the restaurant food specifically when I made that one statement. But I do agree with you that if we do not cover our costs and we do have that increase, we will be in a negative position. But overall, we've addressed fees across the agency to try to increase our fees that we have authority to increase, because our goal across the agency is to provide services and have our costs align. Of course, there are those certain ones that we have to go to the state and try to advocate for. And then in the places where that doesn't match up, it is our goal to work with the county or work across the agency to budget for those accordingly based off the projected volumes. And that's how we do those projections with the OAB.
Okay, because I could get into nitty gritty here. I want to go around. I know others had things to say. Dr. Chan?
Sarah, thank you. Thank you very much.
Oh,
What, did you call
is
on
it
me, or is it
Dr.
up to you? Go
I'm
ahead.
sorry,
Sue.
let's start with Dr. Chan. I'm sorry, and then we've got others in the room here. Sorry, Dr. Vu.
Okay. Okay, so my question is, I think it's specific to the comments on the environmental services. My understanding is that the projected fees were not achieved because restaurants weren't opening at the rate that was previously anticipated. But my question then is, what proportion of environmental services costs are fixed costs, and what proportion is workload dependent or a variable cost?
That's a very good question, ma'am. I'm going to have to come back to you as I don't have that detailed cost breakout in terms of fixed versus variable costs across each individual sub-business unit for environmental services today, because that's going to vary by the different services. That's something I could provide as an action item follow-up for you. We do certainly have that level of cost detail in our accounting system.
Okay, because to the president's comments, if we become more negative with every permit or permit request, that would mean that most of the variance is actually a variable cost, in which case, if there were no, or if there were many fewer requested permits, we shouldn't be as negative as we are. Is that correct?
I'm not quite following. Can you please repeat that?
To the president's comments, his concern is that if we are not covering our costs with each food service permit, we would just become more negative in our income with each permit. But if we weren't getting the anticipated number of permits last year, then we shouldn't be as negative as we are, if those are all variable costs.
Sure, I understand your comment there. There's some complexity related to that. We just weren't getting the volume of revenue in environmental service fees, specifically in retail foods, and that's what's really driving it. There just wasn't the volume there at all to bring in that revenue. So if there isn't any transaction, and you still have staff to provide that service, we still have expenditures there that we're paying for. And so that's really what we're seeing is we still have those operating costs that we're paying for month over month to be prepared to provide those services. And if we're not having customers come in providing even a portion of that fee, even if it's not covering the whole fee, it's bringing in no revenue whatsoever. So we're losing that whole amount.
Yeah, yes, I understand. So in anticipation for this year, those establishments have been opening at the higher rate that was anticipated in 2023. So if those costs of having the employees or services available are already there, then we do not need to be so concerned that we are going to be more negative with each permit request. Is that correct?
Yes, in essence, we are having fees right now that are coming in that are covering our operating costs. And as we move into the February presentation, I can show you that as an agency, our fees as a whole are exceeding our costs. And generally those lag behind our costs a little bit because it can take 30 to 45 days for collections. And so we're seeing a very positive picture of fees relative to our operating costs, which I'll show you in a moment. So
Okay.
I do believe
Thank
as
you.
a whole, the volume is up.
Okay, Dr. Vu.
Sarah, I want to thank you and your team for doing such a wonderful job in this crazy economy and all this craziness. And I think you just mentioned what I was going to ask you to go to slide 11, but you're going to go there anyway. And when you go there, if you can pay attention to, can talk more about the licenses, fees, and permits line item. And if you were to guess a contribution margin for that line item, would it be positive or negative for the first 2 months of 2024?
Yes, sir, we'll cover that as well. Thank you for that comment. I appreciate it.
Okay, General Briggs.
I don't want to talk about environmental licensing fees. I want to ask a different question.
Okay.
And it's for Director Whelan. Just as we look at the expenditures, it looks positive, but I have an inkling in the back of my mind that it indicates a continued staffing shortage. Is that correct? Because we have personnel costs coming under budget, which would then mean we're probably not filling all the positions that we need to fill. Is that still true?
Yes, and I would say within, the last few years, taking note that in 2020 we had to shift to incident command structure and limit and stop programs, and we just began coming back full speed in 2023. So not only are there budget uniqueness as it relates to what's happening, with our agency, and Dr. Vu, I think you had brought up too that it's very challenging, and so we're trying to get back to a steady state prior to the pandemic, and with many of the grant funding and limitations. And absolutely, yes, we have had staffing challenges, and I think came before the board and actually at times had gotten emotional because the burnout, the type of work that we're doing, and just the past 3 years, we're trying to come out of that. And so that is, there's a lot of complexities, as Sarah had said, and we are making progress, but we still do run it probably at a minimum right now. It's better than it has been, but at a minimum of like a 5 to 10% vacancy rate. If you remember, I couldn't even hire nurses, and I actually had to get Dr. Vu, who was very generous, and had a couple of his nurse practitioners volunteer for free for our agency. I could not hire people. I could not, keep full staffed, and that has an impact on the budget as well. And so if you see the fund balance, it is very healthy. I feel very confident as it relates to where we are with the budget. It's going to be a process. We are going to be in a good situation in 2024. We have put in the fee assessments. We started with environmental health, which I wanted to do pre-pandemic. We got that done. We had the entire board support. We are going through program through program doing funding profiles, which means many of our grants have been flat for decades. There are concerns, whether it's women's, infant, and children. They're changing the funding formula, and is El Paso going to get our the appropriate allocation? But in some of our programs, we have not had the time with the staffing and some of the dynamics to go program by program to assess the fees, see what is in our control, or is it in state statute. Some of the contracts, even with efforts in our laboratory, they're not covering their costs, and we can't run a business like that. So that's what we're doing currently. We have been doing, and so we are going to bring up those fees to not make a profit, but to cover costs. And so that is an effort underway that we haven't talked a lot about, but that is where one of my #1 priorities lies, because our personnel and our staffing, our team members, that's our whole business. And to have a healthy workforce that is not so stretched, burnt out, and doing good work, we're still coming through that, and focused on building our agency back or going through the pandemic. And no one wants to talk about the pandemic, and I certainly don't, but the last few years have been extremely challenging, unique, and they definitely have had some budget impacts, and we're trying to get back to a steady, stable state.
Thank you. And I would just encourage that we as a board continue to advocate for the staffing issues that go on. The second thing I will say is that, so when I was in college, I ran cross country. We brought no revenue into the university. We were a total user of the football team's ability to generate revenue. That's who paid for our uniforms and our bus and everything else. So when we look at a lot of these programs, I think adjusting the fees, we have to kind of look at it in the aggregate a little bit and say there will be some places where it is a drain, and there will be other places where it is an additive. And when we look at that balance, I think that nuance will help us to not just go, well, why aren't we making enough money in this one area? Just as a comment.
And I will say that the core funding that the state allocates is extremely important. And also the county funding that is allocated for our agency is extremely important, because federally and statewide, the grants and the contracts do not keep up with the population growth in El Paso County. And it is a continuous effort to try to get the funding for El Paso County that we need. And I try to do all I can, but that is something that is continuous in my 20 years with public health. It's a constant effort as it relates to maintaining funding and increasing funding as appropriate to meet the service demands and the mandates. But that I appreciate your comment, because some of the funding that we do get, it's not going to cover the costs. Whether it's a federal grant, I can say that the Women's, Infant, and Children program, extremely important, but they don't cover their costs. And then they're coming up with a new funding formula that learning more about, but not sure how that's going to impact El Paso County. And then if we don't have the funds to run, even maintain some of the service levels for the clients, then where are we going to pull that money from to make the program whole? And what happens is with the funding formulas, that with staffing, like our staffing are not business units in the sense of like robots, that they can just perform at a certain level every single day. We have challenges of staffing vacancies, hiring people, It takes time to get up and running as it relates to the training and the nuances. There's also different types of leave that we accommodate. And so if we're not seeing clients, then our client numbers don't go up. But sometimes that's a factor in the funding formula, which, if you put more dollars into the staffing to boost the clients, then you're going to have an advantage with the funding formula. There's so many aspects of what the funding formulas are, and then how can we impact that, and how then, who are the decision makers, how can we make that change. But I will tell you that this is something that is steady on our radar, and will be a key priority for now and the future.
I would just like to say that it was just a surprise. We've been told at our previous meetings that everything was looking good, and I think if we had known that this amount, we might have understood it a little bit better.
Yes, ma'am. And, I think Director Whelan, on day one, my very first day with the Public Health Agency, she tasked me to begin this program profile program within the agency, where I'm actually meeting with every program manager. Now that we have a full-time budget supervisor from financial services in the county dedicated to your agency, you're going to be having a lot more support from financial services. We've implemented some training for all the program managers for core competencies in financial management. And so I'm actually going program by program, looking at every single expenditure now very, very closely. So I think that you'll have more of a heads-up display early on if we see these things coming, because you're having additional financial support looking forward. You only had a half-time budget supervisor before, shared with DHS, and now you're going to have a full-time person, working with your program managers here in CSC, sitting with your team. And I think that additional support is needed, especially during this transition post-pandemic, when you have so many factors at play with your grants and your county funding sources. You have a very complex funding picture, and you really needed that additional support. And so I'm hoping that I can provide that additional insight to the board early and often.
Sarah, I know we got you off of your game and what you were going to present to us. I'm sorry, Commissioner Gonzalez.
Yes, thank you. And I don't mean to keep the conversation going on this, so I'd like additional information after this. But based on what I heard, again, going back to Jack's analogy there, what I heard, though, was, okay, I guess, cross-country doesn't make any money, but we'll be in better shape by expanding the cross-country team. That's kind of what I heard, and that's what doesn't make sense to me, and I think a couple other board members. And so I'd like the additional information afterwards. Thank you.
Yes, sir. Okay, I'll move
The football
forward.
team needs to bring in more revenue.
Well, may I just make one more point? So
Yeah.
what is going to help tremendously is that our fees are going to cover the costs in much of the environmental health services, which they haven't done that since 2016. So when we are using county dollars and state dollars, and we didn't put the state dollars in, that we were going to have that cut in June 30th of 2024, we use all of that funding to make some of the programs whole. So I'll be happy to provide much more in detail information, but I do feel that we are going to make progress as it relates to, we're not going to hire more staff and run cross country and think that it just works out well. We are going to be very intentional, and there's a lot that happens with this budget, and we will keep you informed with all of it as well. But I would be happy to connect Commissioner Gonzalez.
So I'd like, was there another question? Or,
I have another question.
yes, ma'am.
I, okay, I would like to say that public health, we all know, is chronically underfunded. And Director Whelan and her organization does amazing things with limited resources. But my question is that if so many of the programs, so many of the grants do not necessarily cover costs, and we do seem to be somewhat over budget regularly, Where does our fund reserve actually come from? How do we get the money that goes into the fund reserve, and what proportion of the annual budget is acceptable to have in that reserve?
Yes, ma'am. That's a great question and a wonderful lead into this next slide. And I would like to just bring up one point. For the past 6 years, we've actually contributed to the fund balance, or actually 5 of the last 6 years, in the positive. You can see 2018, we did use a little bit of the fund balance there towards 2019, but then every year, 2020, 2021, and 2022, we contributed. We're very fiscally responsible. We had some staff vacancies during COVID as those grants came in, and we were well over our 18 to 21% threshold that is our recommended reserve fund balance. And you can see that 18 to 21% in the green is that recommended per our fund balance policy. So we're well over our reserve fund balance. And so most years we actually are operating in the green and being very fiscally responsible and so conservative in our estimates that we are in fact contributing to that reserve fund. This year was a somewhat unpredictable year in those environmental services fees, and so we are asking for that small amount to go into the fund balance, bringing us down to 8.2 million. But you can see we're still well over the 18 to 21% recommended reserve fund, which is that green line for 2023. So we still have a very strong financial position, even though we have an uncertain 2024 as we're post-pandemic, and you're in a very healthy position to make strategic investments in the agency as the board sees fit.
I did want to mention back in 2018 and 2019, where you see the usage of fund balance, that was very intentional, where we worked out a 5-year funding plan where we would have to go back to the Board of County Commissioners every year. Back in 2018 is when I was appointed interim director, went to the Board of County Commissioners to get support for a 5-year funding plan that would equal into $1 million to hire 10 additional staff. And so we were able to have a proposal that it would be a phased-in approach with the Board of County Commissioners' contribution, and then the Board of Health approving a portion of the fund balance every single year, so we could hire 10 additional staff. And where that came, what resulted in that was additional staff that was extremely needed during the pandemic and also at a steady state. But that was a development of our data analytics office, as well as hiring nurses, and then having dedicated emergency preparedness staff here. So that was very helpful. So just wanted to make note that we do not make it a habit to come before the board to ask to use fund reserve. It's intentional around kind of one-time strategic usage, and I think that there's just been some uniqueness related to the last few years and coming out, but I do not anticipate coming before the board and running off our fund balance.
That's correct. And I did run this by Nikki Simmons, the county CFO, and she said our fund policy of 18 to 21%, she wanted me to mention that this is well over the GFOA's recommendation of 16%. So in addition to being over the green line, you're well over the recommended percentage. So you have a very nice reserve balance here, and she was very optimistic that we're in strong financial health. And just to remind everybody what a fund reserve balance is for, it's really an important part of the financial well-being, and it's especially important in uncertain financial times like this to help with unexpected expenditures or when there are risks and revenue shortfalls like what we experienced in financial services. I already mentioned the 18 to 21%, but this is exactly the type of use that we would have the fund balance for. Any questions on fund reserve policy? Okay. And you guys are probably experts at this now after Sam's presentation last fall. Okay. With that, I'd like to move forward to look at 2024 so you can get a sense of how we're doing in the new year. Okay, again, I'll start with, this is the month end, February 2024 managerial report. Our revenues are looking good. I will note that variance on the program-specific grants, I do expect that revenue to come in. It's about a 30 to 45 day delay. We do those expenditures and then we submit those to the state and federal grants, and it takes a little while for those actuals to come back to us. So I do expect by March those to come up a little bit. And so that is why that variance is there of that 268. So I do expect our total revenues to actually increase close to $252,000. So just wanted to explain that variance in the red there for you. As you can see, our licenses, fees, and permits are actually tracking at 1.3 in actuals, where our budgeted was 1 million, and that's why I made that statement to say that licenses, fees, and permits are coming in well ahead of what we had budgeted in these first 2 months of the year. I'll be watching this very closely, given last year's performance. And then looking down at our net impact, we are tracking, I just want to mention one more thing on personnel. We are tracking a little bit lower on personnel, but we have had some success in filling some of our vacancies and had a few retirements in the agency with some large payouts of those individuals. I think you recognized some 30-year and 24-year folks at the last board meeting. So we're doing well in our personnel, filling those vacancies. We're still a little bit under there, which is contributing to that net positive impact of $655,000. Are there any questions? Overall, I think for February, we are in a strong financial position. I'll continue to watch that licenses area closely, but also all of the other business units, particularly our Medicare billing, some of our other business units like laboratory and health services. Any area that I saw any variability last year, we'll be watching those very, very closely for you.
Go ahead, Dr. Vu.
Sarah, you just mentioned Medicare billing. Is there a line item on there for that?
No, sir, we don't report that on the large executive level, but I just want you to know that I always track that month by month because it is an important part of our total revenue. Last year, we were close to $800,000 on that, and it is an area that I always like to watch very closely because it's a nice revenue source for the agency.
Well, Sarah, thank you. Appreciate your candor and tough position to stand there and to tell us that we're going to be going into the fund balance to that degree. I appreciate that. I agree with Dr. Vu that you and your staff do have a difficult and demanding job, and you do have a very complex budget that gets funding from a number of different sources, and some of those are variable, some of them happen and don't happen on a year-to-year basis, and I understand and appreciate all of that. I understand too, and as Susan mentioned, I'm grateful for the county funding that is the kind of the stable factor, and the state per capita funding that helps us to have that stability that we can rely on when other funding sources go up and down, and that you had to make some big adjustments after the pandemic because a lot of funds that poured into the agency were no longer there. With that's staffing adjustments and everything else that goes along with that, and I appreciate that. General Briggs mentioned and I think Dr. Chan also mentioned the understaffing of public health, and we, as a board, we all appreciate that too and understand that. We do, however, understand also that for staffing to increase, funding has to increase commensurately, otherwise we end up going in the hole even more. Vice President or Vice Chair Doris Ralston mentioned that this was a little shocking to us because every month when we sit here as a board, we do get a report, and I realize that you're fairly new in your position. Still, you're not even a year into your position yet, and I appreciate that as well, but every month we sit here and we get the thumbs up that things are looking good, and then when we end up going into the reserve by $635,000, those of us who have backgrounds in managing budgets of organizations, that's not good.
I understand.
So if you heard frustration coming from this chair or from any of the board members, please understand that we want to make sure that we're in a healthy position moving forward. We believe in what we do. We believe that we provide essential services to our county, and we got to make sure that that is stable for the long haul. And, you know, I grew up in the city where going into the reserve fund was not a thing that we did. So it was a shock to me. But I do appreciate that you are on board now, that we do have somebody from finance who is dedicated to our organization. So on a month-to-month basis, when we get your reports from the, during the board meetings, when we get the thumbs up, I hope that we all are on the same understanding of, okay, that we're all on the same understanding that we're moving forward, and we're not moving forward into the red. We're moving forward maintaining the black. That's what we're hoping for.
Yes, sir. And I will just say I do have a very interesting background. You know, as a military background, an Air Force pilot, there's a very thin margin of error there, sir.
I bet.
We run a tight margin on that. You know, it's gas in the tank, it's your airspeed, it's how much runway do you have left, and you can't be wrong on these things. So
you're bringing a tear to the general's eye.
So, you know, my military side's coming out, and then after that, I ran a small business, and you know, if I was wrong on the budget there, it was going to be my children's college education and the mortgage of I'd lose my house. So, I am going through this line by line, sir, until I have it down. Day one, Susan Whelan, Director Whelan, sat me down and said, I want these program profiles up. And I'm working diligently with Lee Perry, the new Director of Operations. She's my wingman in this, and wingwoman. And we are going to get you accurate data on time.
Thank you.
And we will provide this data, be it good or bad, but you will have those facts.
Thank you.
Okay.
And just know that this board is ready to hear any presentations that will take our, if our fees are not matching our expenditures, we want to know about that. We want to hear about that and make any adjustments that we need to do, okay?
Yes, sir. I won't delay in reporting any financial information that's relevant to the board.
Dr. Chan has another question or comment?
Yes, I have a question, very, you know, just a small technical question. In December, I recall that there were a number of expected capital expenditures that had not been invoiced yet. And I noticed that there is a variance in expenditures for capital expenses. Have all of those improvements that were completed in 2023 been invoiced and paid?
Yes, ma'am. My understanding is that those have been completed and paid for 2023. I can confirm that by email to you to make sure, but I did check with finance last week as we were nearing closing the books for 2023. And I believe the public health audit is starting April 1st, and so they were closing those out. So my understanding is those are completed and paid at this time, and that is our final numbers. But I will confirm that by email with finance in writing so that I can be certain of it for you, ma'am.
Thank you.
Yes. Great question.
All right, Sarah, I think you're off the hook.
Okay, thank you, sir.
Okay, that takes us to item number 6 on the agenda, and we have a resolution for CDPHE Capital Building Regional Workforce Grant.
Mr. President, would you like me to read that into the record?
Yes, I would. Thank you.
Resolution number 2024-5, resolution to recognize revenue and appropriate expenditures for contract funding, effective March 27th, 2024. Resolution of the El Paso County Board of Health, resolution to recognize revenue and appropriate expenditures in the amount of $80,000 for Business Operations Director grant funding as contracted with the Colorado Department of Public Health and Environment, CDPHE. Whereas pursuant to Section 251508 Colorado Revised Statutes, the El Paso County Board of Health has the power to and duty to accept and through the Public Health Director use, disperse, and administer all federal aid, state aid, and other monies allocated to an agency for county public health functions. And whereas the funding within will fund 0.42 FTE of the annual salary of the Business Operations Director. This position directs the strategic analysis of agency-wide business operations to include overall direction and strategic planning for the EPCPH business operations. This position oversees the effort to streamline structures, policies, and practices related to budget oversight and management. This position assists in aligning business practices and to the needs and gaps identified by the workforce gap analysis, and leads the formulation, implementation, and evaluation of business plans and strategies for agency administrative operations. Whereas the Business Operations Director advises leadership and staff of new directives, policies, and procedures, and leads information sharing, cross-training, and skill building in the effort to maximize efficiency. This position identifies, monitors, and evaluates grants and additional funding opportunities, and provides fiscal oversight of agency budgets. The Business Operations Director serves as the central point of contact and is a liaison for the agency to El Paso County Finance, Payroll, Budget, and Procurement. Now therefore be it resolved that the El Paso County Board of Health does hereby recognize revenue and appropriate expenditures in the amount of $80,000 to the El Paso County Public Health 2024 budget in the following manner. Recognize revenue 531.0001.33400, Business Operations Director grant $80,000, appropriate expenditures 5300001.41102, salaries full-time $80,000, done this 27th day of March 2024 at Colorado Springs, Colorado, El Paso County Board of Health, by President Ted Colas, attest by Secretary Susan Whelan.
Okay, we need a motion and a second to accept this resolution as read.
I would move, this is General Briggs, I would move to accept the resolution as read.
Okay, thank you, General Briggs. A second?
Second.
And thank you, Commissioner Gonzalez. All in favor of this CDPHE resolution, let it be known by saying aye.
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 And any opposed? And there is none. The resolution passes unanimously. And that takes us to item 7 on our agenda, the Director's Report. And I'm going to turn it over to Director Whelan.
May I ask Summer South to come up? Is she in the audience? Wanted to introduce a new team member who has been promoted within our agency, and her name is Summer South, and she is our Clinical Services Director. And Summer, maybe you can bring a tear to General Briggs' eyes as well, and maybe say something about the military, and because you have a military background as well. If you could introduce yourself, please.
Yes, thank you, Susan. Can everybody hear me okay? So my name is Summer South. I was previously the Reproductive Health Clinic Program Manager here. I started here in 2021, and prior to that, I was a labor and delivery nurse at Memorial Hospital Central and North. But prior to all of that, I was in the military. I served 7.5 years as a military police officer, active duty, 2 tours in Iraq, led a team during wartime. And, you know, I'm just incredibly honored and proud to be a part of public health. It's a vastly different world than military service to some degree. There's a lot of commonalities. A lot of that I really appreciate the structure. And I plan to bring my military background, my striving for excellence to this position, especially as a division director at this point in time. I'm honored to serve with all of you, and I'm very, very excited to support our community, and especially because so many of our citizens, as we know, are veterans and current active duty service members. So thank you all. Susan, thank you so much. I appreciate it, and I'm excited for my time. All right.
Great. Yeah, congratulations. It's always great to see people promoted from within.
Mm-hmm. I agree. All right. Next up, we're going to have a couple of presentations and some highlights. So, Michelle, are you starting off? And we'll get more into the data dashboards as well and the behavioral health platform.
Good morning, board members. Michelle Byerly. I serve as the Public Health Information Officer, and we are here today to go over some data dashboards that we have recently launched. As you may recall, we were here previously in January as part of an overview of many of our agency plans. This was a component that we were finalizing, and we are excited to be able to share with you a little bit more today about this initiative. So I will give a brief overview, and then I will ask two of our data experts to come up and share a bit more with you, and then we will close with our behavioral health planner, who will provide some updates on a project that we are doing to enhance the availability of Narcan in the community, as well as the Behavioral Health 360 online platform. So as a brief recap, we have recently launched in early February 2 data dashboards, one which focuses on suicide data and one which focuses on overdose. And these are very much interconnected with all of our agency plans. One of the things that we are very proud of is the fact that this will be the first time that as part of our community health assessment that we are pairing some of those leading health issues within that assessment with data visualizations. We are always looking for ways to modernize and improve how we're sharing that data with the community, and really the overarching goal is to provide residents, partners, stakeholders, everyone in the public with access to objective, clear local data. So a few of the features of the dashboards, they are intended really to be as easy to navigate and understand as possible. We do lead in with resources, understanding that these are tough topics, so we want to make sure always that we are pairing any of this data with some resources, whether that be a crisis line, a website to help support people. We have separate topics on our dashboard, so they are broken out by topic area. The data elements are consistently presented across both. We did a lot of work on the back end to help ensure that the dashboards worked with a number of different devices. We know folks are often looking at things like this on their phone, on their tablets, on their desktop, so making sure that the information is accessible. We have it available in Spanish, and then in addition to the visualizations, also pairing that with narrative, so people get, anytime they're looking at some of those trends, there's also text and information to help complement what folks are seeing. And then we do have some hover over features as well, which provide additional information. And with that, I'm going to ask Alicia Humlicek, who's a epidemiologist with our data and analytics team, along with Dr. Bernadette Albanese, who is our co-medical director and medical epidemiologist, to share a little bit more about the data.
Good morning. My name is Alicia Humlicek, and I'm an epidemiologist on the data and analytics team, and I'm pleased to present the dashboard presentation today. I want to take a moment to remind us that,
Go ahead.
okay. I want to take a moment to remind us that every number shown here represents a person. And we know that each person lost has significant impacts on friends, family, and community. And as I present the data today, I also look forward to the opportunity to discuss resources and support to improve these issues. Okay, so this is our homepage. This is the data dashboard homepage. And as you can see, viewers can navigate to this page on the left-hand side. Let's see if this pointer works. On the left-hand side here with this menu, or on the top section here at this navigation bar. And so you can get there a couple of different ways on the website. And once you get to this homepage, you can also navigate to the different dashboards, either the suicide data or the overdose data, or you can use these buttons here. Like Michelle mentioned, we do have some resources here just to lead in because these are heavy topics. So we have the Colorado Crisis Services hotline, and we have an option here to find mental health or substance abuse treatment. So we're going to go right into the suicide dashboard here. So I'll be presenting the suicide dashboard overview, and Dr. Albanese will be presenting the overdose. The suicide data dashboard consists of 2 pages, a summary of deaths by suicide, and the suicide deaths by manner. And here's the intro text here, just explaining the importance of this issue to our community. and how our aim is to really provide access to local data in the hopes of preventing these tragedies. So this is the first visual, and this is a summary of the total deaths by suicide over 10 years. On this visual, we see the count of suicide deaths and the rate per 100,000 people, and the light blue bars are the count per year, so this is annual each year, and then the darker blue line is going to be the rate every year. If you were to look at this on the live dashboard, you could actually hover your cursor over these data points and see some additional information. Just to explain this visual slightly, on the left-hand y-axis, we see the count. On the x-axis is the year, and then on the right-hand y-axis is going to be the crude rate per 100,000 people. And as it mentions here, we have seen these counts and rates increase over historical trends since 2019 and essentially has stayed the same since. This next visual shows the suicide rates by sex. And as you can see here, males consistently have higher suicide death rates as compared to females. And in 2022, this was 3 times higher. Again, if you were to look at this on the live dashboard, and if you were to hover over any of these data points, you would see for that year the count as well for male and female and the total for that year. This visual is the suicide rates by race and ethnicity. This data is data from 2022 through, 2020.
Could I ask one question about
Sure.
the previous slide?
Sure.
The overall rate is 25, right? 25 and a half in year 2022. But here we have males at 38 and females at 12. So the 25 is the combination of the two.
Yes, it's over total population.
Okay, thank you.
Mm-hmm. Okay, so again, in this visual, we have data from 2020 through 2022 combined. And we do that many times when we have smaller numbers in order to show more data. And on the left-hand side here, we have the race ethnicity categories, and then following to the right, we have the count and the rate for those categories. And at the very bottom here, we have the total, or basically the count and rate for all races, ethnicities combined. We have them listed in order of rate with the highest rate on top, and then listed down in descending order. One thing I will mention as well is we have an asterisk listed here, and that is explained in the footnote, which is we use an asterisk when we have data that we need to suppress due to small numbers, and that is done for confidentiality and privacy concerns in specific categories. One thing I want to make note of is when we look at categories with small numbers, we usually look at counts and rates. For one, because it helps to normalize across different categories, but also because we have such differing population numbers that can really affect a rate. And so we want to make sure we look at the counts as well. Another thing I failed to mention previously is that the data source for each of these visuals is listed in the footnote at the bottom of the visual. The next visual we have here is suicide rate by age group. And this is an annual rate, but we do have this year filter in the top left-hand portion of the visual. And if you were to click on that, it would be a drop-down, and you could choose the year to look at, and it's over 10 years' time. Again, if we did have an age group that we could not represent due to data suppression, that would have an asterisk listed as well. In 2022, we saw the 45 to 64 year age group have the highest rate of suicide. However, the 25 to 44 year age group has the highest count. And again, if you were to hover over this, you would see the count and rate for those age groups for that year. And this is the first visual on the suicide page that is suicide by manner. And we're just going to look at this first visual here on this page. This visual will show the top 3 manners of suicide deaths. And among individuals who died by suicide, firearms were the most commonly used manner. And next was hanging, suffocation, and strangulation. And then third was the percent by drugs and other biological substances. And so what you're seeing here is the percent, the percent of total suicides attributed to that manner. So as you can see, firearm has been the most commonly used manner over the course of time, and then it has reached over 60% of suicide deaths in the last 2 years.
I think we have a question.
Okay.
It's very difficult, I understand, but in the the numbers for overdose, are we including, I guess maybe the question is, how are we including overdose as some of it might be considered accidental versus purposeful? I'm just trying to understand, maybe, Doc, maybe you can help me understand at least what the parameters are when the coroner or maybe yourself or somebody else makes an analysis like that.
Hi, great question. Dr. Albanese, co-medical director here at the health department. So this will be a little clearer when we go to the overdose dashboard next, but so the determination of suicide is, since all suicide deaths are investigated by coroners, it's essentially made by the coroner. So any certifying physician that fills out the death certificate has made that determination, and coroners, unlike someone who may, pass from a heart attack or something, and that determination might be made in a hospital setting, for example. The coroner, was referred also with potential suicide cases. They do an investigation of circumstances and police reports and so on and so forth to make that determination. Once that data gets to vital statistics program at the state health department, they're not second guessing anything. They just take that data and do that. So what you'll see when we go over drug overdose in particular, and this is drugs and other biological substances. So it's not, the circumstances around a drug essentially being the manner of suicide death could be a little bit broader than that. But overall, for all drug overdoses, 90% of them are unintentional and 10% are intentional. The 10% intentional are suicide. So it's a little, it doesn't show it
I
this way.
totally
but
understand. I just wanted to know if there was some sort of standard that coroners would use, because I know how difficult this could be. It could be somebody who just says, I don't care anymore. Now, are they committing suicide or are they just overdosing?
That would be a question for the
Right,
coroner.
yeah.
I can inquire for you, and we can let you know.
That would be interesting. I don't mean that in a cavalier kind of way, but I do think that would be an interesting point to better understand about how we generate that data.
Yeah.
Right.
I mean, but the fact that the far majority, 9 out of 10 drug overdose deaths in Colorado, and that trend is true nationally, are unintentional, meaning
Okay.
accidental.
Thank you.
Okay, all right. And then this visual is the same visual we just showed of suicide by manner, but it does show the hover over feature. And so as you see here, like right here, we're looking at the percentages of the total, but it will give for that year. So this is 2020 highlighted, which is listed in the bottom of this pop-up window, and it gives you the count of total suicides, including all manners, and then the counts of these 3 categories. There are others, but these are the top 3, and as you can see, vast majority of them are included in these numbers. That is the last visual I have for the suicide data dashboard. Do we have any questions before I turn it over to Dr. Albanese?
I don't see any questions. Thank you very much.
make sure I know how to use this.
Oh, Dr.
Oh, okay,
Chan does
great,
have a
yep.
question. Oh. Go ahead, Dr.
A
Chan.
quick question about the dashboard, which I find incredibly useful. Does it, is there any tracking of how many site visits you'll be getting?
Yes. Yes, we can track that.
Thank you.
I don't have the numbers right now, but we can track that.
Mhm.
And we're adding one to the count because you're on there. All right, Dr. Albanese, co-medical director. I am going to cover the drug overdose portion of the dashboard. So you'll see immediately the consistency in how the data are formatted and presented with drug overdose. So on the top, the two major subcategories is a summary of overdose deaths, which will look a lot like Alicia explained very nicely in her presentation. And then we have a focus on the drugs involved with the drug overdose deaths. We have a little bit of a summary section on the top, and then we go into the data sections, which mimic how we organized it for suicides. So the top section describes the number and rate per 100,000 people of all drug overdose deaths in El Paso County. Same format for this graph on the left. We have it by year from 2013 to 2022. We have both the counts in the light blue bars, and we have the accrued rate per 100,000 people in the dark blue line with the numbers for each year demonstrated. We also accompany this with a very simple interpretation of the graph for this period of time. And I think, unlike the suicide deaths with trends which maybe bounced a little bit and leveled off, we clearly, for our county, have an inflection, a significant inflection of drug overdose deaths between 2019 and 2020. And so when you look at the 10-year trend, it's a marked increase, but much of that trend is really from 2020 onwards. A little bit of dip downward, which is always a favorable one-year trend between 2021 and 2022, and we will see where that goes over time. The next section, again, similar to how we presented for suicide, is drug overdose deaths by sex. Again, we have year 2016 through 2022 by year, and we show the rates, the male rate in blue and the female rate in orange. And pretty consistently, we see that drug overdose death rates in males have remained elevated. Those that we see in females into 2022, that difference was about 1.6 times higher in males than in females. The next section looks similar as well. This is drug overdose deaths by race and ethnicity, also combined for the 3-year period, 2020 through 2022. Similar format, we list the race and ethnicity categories on the leftmost column, followed by the middle column, which is the count of overdose deaths during that 3-year period of time, and then the rate adjusted for the size of the population for each of those race and ethnicity groups. Here we see the impact of small numbers that Alicia was alluding to. So overall, the majority of drug overdose deaths are occurring in our white non-Hispanic population in El Paso County, followed pretty significantly lower by Hispanic persons of any race, and then by count, Black or African American, and then much smaller numbers. When you look at the rate column, the farmost right column, you will see the rates bounce around a little bit, and so you will see the highest rate actually occurring in American Indian or Alaskan Natives, followed by Native Hawaiian or Pacific Islander. But if you look at the absolute number of drug overdose deaths in those categories, they're exceedingly small, making up less than 2% of the total. And so we have a very small number of people in our community in these race categories. And so if you have 2 in a very small population and then 1 year it becomes 4, the rate is going to double simply by the math. But it doesn't. But the overall burden of drug overdose deaths is not falling on those particular populations. Okay, the next section is drug overdose deaths by age group, and set up the same way as suicides. This image is showing data just from 2022, but using, on the live site, using the year filter, you can switch that and the rates will change accordingly per age group. But essentially for this particular topic area, since 2021, persons aged 35 to 44 have remained top of the line in terms of the highest number of drug overdose deaths and the highest rate of overdose deaths. So drug overdose deaths are disproportionately impacts persons essentially between 25 and 44 years of age. And I didn't actually point this out on the first slide, General Briggs, but that's where we notate that 90% of drug overdose deaths are coded as unintentional accidental.
Thank you. General Briggs here for the record. Maybe you'll get to this, but is there any data that's collected indicating either, I do not like this term, but recreational or occasional users, vice chronic?
That data might be, so both suicide deaths and drug overdose deaths also being investigated by the coroners in many instances, do undergo further review by select committees at the State Health Department. So suicide deaths are considered violent deaths along with homicide, and drug overdose deaths sort of their own category. And so and then that data is aggregated statewide, and then it's split up by county. And so in those data reviews by the state, they essentially take the coroner reports and medical records around the time of death and other available reports to try to make some assessments around the circumstances of death. And so I will go back and take a look. Michelle, please make a note, and take a look if about what the history of drug use was for the circumstances, and see if that's called out, and I can get back to you.
Thank you. So anecdotally, we would maybe tease out the information about how deadly fentanyl is. And
Yeah, we're gonna get the fentanyl in a
I know you have a
second.
slide for
Yeah.
that, but you know, the intent would be to maybe have data for the community that shows the acceleration in overdose deaths due to fentanyl.
Exactly.
Right, because of its one-time use and a potential to kill someone the first time they would ever use it, as opposed to heroin or cocaine or something like that.
Agreed, and there'll be a little more information on the next slide
Sure.
coming up. I will tell you, having looked at this data for youth drug overdose deaths, a significant, in just for other work that I have done, a significant proportion of those deaths are, I tried it and it went bad quick. And so I think for youth, you can pretty confidently say that some of that is experimentation gone wrong, gone seriously wrong. Okay, so the next section on the overdose dashboard gets into overdose deaths by the type of drug involved. So let me explain what that means, because it's a very specific terminology in Vital Statistics around this data. So again, when Vital Statistics receives a death certificate coded as a drug overdose death, it's common for the certifying physician to list one or more drugs that they think were involved with the death. It doesn't always mean that they, through their examination and through sort of understanding the circumstances of the death, that they can actually decide on one. So it may be that they detected multiple drugs in someone's system at the time of the death, but it's unclear to say, I don't know if it was a little more of this one, a little, and so they won't attempt to do that, because sort of physiologically, it may not be appropriate, that they're just unable to distinguish. I mean, ultimately, if someone passes from a drug overdose death, either a couple of things happen. One is very likely they've just stopped breathing, and that doesn't work, right? Or perhaps they had a cardiac event, right? And sometimes it's just impossible to tease out. So what Vital Statistics does is saying, I'm not trying to judge it either, that's not their role, but they will include in the statistics any of the drugs that they would say potentially like involved in the death. So that terminology is intentional. And so the most common drugs involved in deaths, not only in El Paso County, but in Colorado, historically have been methamphetamine, heroin, and cocaine. However, over the past several years, fentanyl, which used to be less than 10%, less than 20% involved, meaning mentioned on death certificate of death, that has changed dramatically. So if you go to the website, this is one section where using the year filter is extremely informative, because you will see methamphetamine, some roll of heroin, and then over the past 2 years, you'll see a little bar for fentanyl, and then a bigger bar for fentanyl. And then in 2022, for the first time, at least in the data that we look back, which is usually 10 or more years, we saw fentanyl-involved percentages exceed those from methamphetamine. And that is it. That is the story. I mean, behind any drug overdose, there's a massive story about behavioral health issues and societal challenges and socioeconomic challenges and just, mental health issues that are pervasive. And that data is available on the drug overdose review system. But the fact that fentanyl was part of that, terminal event, is really different than before. And so when you go, I'm going to just give you an example of the hover. So this hover feature, which we just demonstrated for this slide, will show the percentage of fentanyl involved in 2022, and then the number of deaths for which any one of those drugs were mentioned. And it's not uncommon to have one or more drug listed. So you could have someone with cocaine and fentanyl and heroin, for example. So really almost any combination might be presented. So here's our fentanyl slide. This is the story. And so you go from 2018 to 2019, it more than doubled. This is a number of drug overdose deaths involving fentanyl. Double over 2018 to 2019, double over 2019 to 2020, more than double over 2020 to 2021, and then another little kick up. So we have more drug overdose deaths because fentanyl is a significant contributor. Is it the only one? Not necessarily, but is it a contributor? Yes, it is. And so this is the story that we thought was important to tell with this dashboard, and hence we're showing you these examples. Okay, so let me stop there and see if there are any other questions.
I'm sorry for
Nope.
barging in again. This is just in my wheelhouse. So, because I want to make sure that we're presenting data that's useful for the community. One Chance to Grow Up Foundation published studies that show that the #1 substance in youth suicides, meaning someone who's committed suicide, the substance that's in their body is THC. So, while and the power of what THC is today is it's rocket fuel, and it is psychotropic, and that is, so there's some connection there. And I wonder if maybe that might be something that we could also include as a, disregard everything after Commissioner Gonzalez. But we're not talking about the most common drug that's used outside of alcohol. And maybe even that's a statistic that we would like to include as alcohol, because those are very prevalent, obviously, in our society.
Mr. Chair. Thank you. Yeah, so I was going to wait till the very end, but so what I was interested in was the suicide data, not the cause of the suicide, but how much of the drugs or types of drugs were, or alcohol, in the bloodstream of the person who had successfully committed suicide, but not because of the drug. I think that's an indicator, as Jack just mentioned.
Yeah, we'll have to see if that data is actually available, because if it may not be listed on all death certificates as something that would be readily available, but we can look.
Just on this topic, I think when Dr. Finn was here last month, he pointed out that exact point, that the most common substance is THC in a lot of different bad things, one of which was successful suicides, and I'm not sure about attempts, in youth. So that's a good point. That might be very interesting to see and be a real warning for parents, those who think that this is safe, it's okay to use this, to see this is very prevalent in suicide attempts and successful suicide. So I would support that.
Yeah, and I think both of the drugs mentioned, both the THC and alcohol would be contributing factors. So if that data is available for both of the dashboards, I think it would be helpful. And Dr. Chan, you have a comment, question?
I have a question in terms of the fentanyl overdoses. Is there any way to know what proportion of the overdose victims actually knew that they were using fentanyl?
I've looked at the drug overdose review data fairly frequently, and I'm not sure that indicator is systematically captured. I'm not sure that, meaning you bought a pill, it was a certain color, you thought it was something, and you took it and it was fentanyl, or now veterinary drugs, xylazine. So I'll look again, Dr. Chan. I'm not sure that level of specificity is available, but I'll look. I'll look.
Any other comments from the board? I'd like to thank you guys for putting these dashboards together. They provide a lot of useful information. If not cheering, uplifting, it's useful information for our community.
Exactly, and that's the point ultimately. The end. Like these are, we're just digesting the facts available around vital statistics for these deaths. This is not explaining the whys things happened or the underlying conditions per se. Again, some of that information can be made available as well, but it is to raise awareness, stimulate discussion, and bring community together to talk about prevention. That's ultimately where we want to go.
One thing that I had mentioned to Susan when we talked about this particular meeting and these dashboards are being presented is a request maybe to have another dashboard that shows what our county is doing, what our Board of Health is doing, what programs are available for support of individuals that find themselves either contemplating suicide or experimenting with drugs or even the chronic user of drugs, that shows all of the resources that are available, the things that are available, how many times people participate, and to show the good work that is being done by our health department and have it right alongside this data so that they can quickly go into see what's available to them. Go ahead.
I was going to just ask if there's any intention of doing a news release or doing some social media so that the public knows that this dashboard is available, and then as the resources.
You brought a tear to.
I wanted to mention, so we've already done a news release and sent it out, but over the past year in 2023, we've worked on about 9 different plans as it relates to kind of regrouping from the pandemic. That includes our community health assessment. We're working on a community health improvement plan, strategic plan. There's so many different plans that we're working on, and so we were able to launch the data dashboards prior to having the finalized version of the community health assessment. And so I expect that the community health assessment should be available sometime in April. And so we will do a public launch of that and then do more of a demo with the data dashboards. And I think that this is great because a lot of the questions or the comments are leading into the next session with Maggie Yokohana. We're going to talk about a behavioral health platform that we're working on. And I will say to Dr. Bernadette Albanese, who mentioned that, our role is to serve as a credible data source. Our public health role, we certainly don't have the capacity to be the sole fixer or working on all of these issues. And many of these issues are very complex and involve numerous different organizations. So I will say that with the Healthy Community Collaborative, that is over 80 different organizations within the community that we work with, that there's different slices of the pie related to prevention or treatment that our partners are joining us in. But one thing that they can count on is that we are trying to have timely, relevant data so they can use as a resource to support the work that they are doing. And I love your comment too about how can we pair what resources are available with some of these heavy issues and complex issues, as well as how can we highlight our local efforts from our public health department. So with that, I'd like to ask Maggie Yokohana to come up, who is, this is a new position, grant funded, a behavioral health planner. And we have an innovative behavioral health platform that we are just building. Over my 20 plus years, I've been at numerous tables that say it would be great if we had a one-stop shop resource, just with updated information. Here are my needs, what can I get? And this is the system which we learned at a National Association of City and County Health Officials that we are working to customize. And our vision is for this to be a resource with people having behavioral health issues, mental health, wanting some self-care, that well-vetted information from clinicians as a resource. So we are building it, and there will be different phases, but it's not ready to launch, but we did want to provide more details and get some of the feedback from you all about this platform. And we are not going to call it the behavioral health platform. It's going to be, our communication and marketing is going to work with the city and the county to see what we're going to name it. So we're just referring it to as the behavioral health platform right now.
Great, thank you. And again, my name is Maggie Yokohana. I'm the El Paso County Public Health Behavioral Health Planner. And I'm going to actually just share a little bit about our Narcan project, especially as relevant to what was just shared on those data dashboards. And so just wanted to share that we and El Paso County Public Health have joined in the efforts alongside of many other agencies and entities such as law enforcement, schools, other county agencies like DHS, in terms of accessing and distributing Narcan. We just started about 6 months ago in terms of accessing the state supply of free Narcan and have been distributing since then, since late, I think, September, August time. And so far have distributed over 1,000 kits, Narcan kits. And these kits have been distributed through a number of our programs where staff have been trained to administer and also distribute Narcan. And so actually a lot of our recipients have been walk-in clients. They've also been through our youth suicide prevention work group, through our women, infant, and children front desk staff as well. And so lots of different avenues where Narcan is getting into the hands of our community members. And so I'm just going to share a little bit of some of the impacts that we've already seen. And so again, mentioning the over 1,000 kits, and that equals over 2,000 doses that have been distributed for free at no cost to individuals. And again, that is coming from our state supply of the naloxone bulk fund. And that just, again, wanting to touch on how that's a low barrier, because otherwise about every Narcan kit from like a pharmacy over the counter is about $45. And so that can be very costly for some individuals. Another outcome has been some of our key community partnerships and being able to work with these partners in our community to further distribute Narcan or resources, or understand what resources they provide so that we can provide it further through our own channels and programs as well. And then lastly, increasing awareness and education, so especially around fentanyl. And so we do have handouts and information around fentanyl 101 fact sheets. We also provide recovery resources and connections and coordination to other programs, and again, those resources in our community. So it's kind of a holistic approach to not just handing them a Narcan kit, but also providing these resources that are in our community, and then also any kind of questions that might arise to get that feedback as well. Before I move on to the next, to the platform conversations, any comments or questions about our Narcan project? Oh, and you can get them at all of our locations. So all 3 of our locations provide Narcan, so please spread the word. Okay, yes.
I have a couple questions. So the Narcan kits cost El Paso County Public Health nothing?
Nothing.
We get them for free?
Correct.
Who can go in and pick those up? Can a 13-year-old go in and get a Narcan kit?
So currently, we do not provide to minors unless they have an adult accompanying them. We make sure that anybody who's distributing will confirm with that prior to providing the kits.
Can someone pick up more than one?
Yes.
How many? Could one person go in and say, I'd like 20 and leave with 20?
No, so if they do ask for more than just like 2 or 3, we do ask them to connect with me. And that way, if they are a community partner, they are able to kind of go through the different avenues of getting trained in Narcan, also learning about how to access the state supply themselves directly, and then get any resources so they can continue the process.
And we had some questions last time about, hey, are there any studies? Does this encourage risk-taking behavior? Do teenage boys think, well, hey, we're okay now. Let's try this stuff out because if anything goes wrong, we're good. Are we aware of any studies that investigate that?
Yes, so there are a couple studies that I have on hand from the state that I can provide after this that do show that because of since their efforts, this has been happening, this Narcan distribution has been happening since early 2020, 2021. And so they have shown that this has not increased any risky behaviors. It has not been associated with risky opioid use behaviors because of that kind of last safety net idea, but it has not shown increases.
Okay, thank you.
Thank you. Great questions. Okay. So I'm going to go ahead and share a little bit about our innovative online behavioral health platform and just a little bit information on that. So this is a web-based platform tailored to our community that's a low barrier access to mental health resources, self-help tools that, again, are free, confidential, and accessible. And so we'll be launching that hopefully soon with some of our behavioral health partners in the community. And so just to provide a little bit more information and not to get too into the details, but this platform will provide over 1,000 of resources vetted by experts. And so this includes clinical psychologists, psychiatrists, behavioral health doctors and nurses, licensed social workers, and so forth and so on. And so this also provides numerous types of resources that review over 200 topics ranging from stress and depression to even something as light as like your health goals. And it provides self-care tips, mental wellness practices, again, vetted by those team of professionals. And then also the content provides different types of resources types, so like podcasts, videos, articles, books, and more based on kind of what the individual is looking for on this platform. And there's also assessments that provide a very high level understanding on where a person's mental health might be, what are some potential strengths as well as challenges. And again, these are validated assessments from existing mental health screening tools. And so currently we are working closely with some of our behavioral health partners to launch this platform soon, as mentioned earlier. But again, wanting to share that this is kind of one of those first steps to your mental health tool, or it can be something that supports a robust way to support somebody in their ongoing journey. But it does provide accessible content that's free. It's available in Spanish. You don't have to have an account to use it, but you can if you'd like to track resources. And it can be accessed across multiple devices, again, computer, phones, tablets. And then it is credible. So again, it is developed by a team of experts. It's evidence-based resources and practices that are included. And it's confidential, so the data is never shared out. You don't, again, that piece of not having an account, you don't get tracked for anything. No identifiers are collected. It's just a resource to get into people's hands.
We have a comment?
Yes.
That's General Briggs. So thank you. And I would like to ask, is there going to be a feature on the site that answers the question that everybody who's in this situation has? My child, my husband, my wife, my friend is devolving in front of me. I don't know who to call. I don't know what to do. Help me, right? This is the problem. This happens in a family or a workplace or something, and people don't know, like, how do I talk to somebody or get my loved one connected with somebody that is specific to my issue? I'll raise veterans, right? There's the VA's hotline, and I get it, right? So there's resources that are pointed in that direction. But I have a 12-year-old who's said something crazy, or a 15-year-old that said something crazy in my family, or my husband just said something crazy. What do I do? Is there a place that I can go on this website and start getting connected
Yes, so great question. So
with a pro?
yes, yeah, so this won't provide direct connect, it won't have like any behavioral health or mental health providers behind it. But it does have the option, and that's what the community partnership piece will come in, where we have a customizable piece that will lead them directly to local resources based on maybe where they are, what they need. And so if they are looking for those types of services, maybe they take an assessment and this shows maybe severe depression or self-harm. It may be indicated in some of the things they were looking for. It can be, again, redirected in a customized way to a local resource, a local behavioral health provider or clinic. And some of the resources on there might also be kind of resources around how do I talk to my child about this topic, or you search any word or topic, it again will gear you towards it, and it'll give you options of like, I want to figure this out on my own versus I need help. And so some of those that might show like higher crisis needs will have links to, again, the 998 line. It'll have who to call. But then again, if they want to, what makes it geared towards our community, it will be that community partnership of this, you know, Peak View is in this area and that can provide these resources, or Diversus has these providers that have these topic areas covered. So it will, through this partnership, be customized in a way that can lead individuals direct, you know, resources if they're not looking for just those kind of self-paced self-help.
So maybe taking a page from hospitals and the healthcare system, you always get that when you call, if this is a medical emergency, hang up and call 911. Right? Maybe there's something that if somebody goes to the website, and if you or someone is experiencing a mental health crisis, hang up and do this.
Yes.
Right? You know, something like that as a starting point, because I think the mayor's wife and other advocates for where we're going with this are realizing how difficult it is for someone to discover, like, what can I do to help my loved one now? That, I think, is a very important piece. So I don't know how to weave that into this. I love this, but you know, I think there's another first step.
Definitely.
I would also say that we're happy to do a more in detail demo, because what we're doing right now is meeting with numerous different groups. We are not behavioral health experts in public health, and so what we are doing, we're meeting with the leadership of, for example, like Diversus Health, Peak View, the Lida Hill, and other elected officials and community, because we do want to be thoughtful about how we launch this. And yeah, with every resource, there has to be a standard. You know, if you are experiencing a crisis, hang up and call 911. So there'll be multiple different layers on there. I do want to emphasize that this will be a pilot to see how this goes. It is not the be-all, end-all. It's part of enhancing the already ongoing good efforts that are happening in the community. So, for example, there's the 211 line where people can call and they don't have a computer. But what goes behind the scenes with that is that we all provide the resources. So this will be much different in the sense of more enhancements as it relates to behavioral health and an online platform. And so as we go, we'll make sure that we adjust and very intentional around the 988, which is a crisis line, but it's also a prevention line as well. So there'll be different resources on that. So any feedback is very welcome, because we are envisioning that this will be one more resource to help those individuals out related to their unique situation. And there will be assessments on here that can, you know, offer some evidence-based suggestions. I think that Mr. Donaldson, you had mentioned the importance of getting out in the sunshine and healthy eating, active living, and taking a walk to improve mental health. So that's part of this. There's so many different options that will be available on this. So I'm very excited about it, but we are all cautious as it is a pilot. But I would welcome the opportunity to go more in depth to show you the demo prior to launching it. And so we're being very thoughtful about not launching it too quick. And we have many more demos that are actually scheduled to get some feedback with our community partners and leaders. And Dr. Chan has a question also.
Okay, go ahead, Dr. Chan.
Okay, I just had to unmute there. This goes back to the Narcan. Sorry, I didn't ask that question earlier. I wanted to see the whole presentation in case it was all tied in together. But I have two questions about the Narcan. Number one is when you are distributing Narcan, particularly if it's to an individual, is there any avenue at the point of distribution to get them into rehab or connect with a community partner rather than just giving them the Narcan and the training on how to use it?
Yes, and that's part of our increasing awareness and education piece. So with the Narcan that's provided, they are redirected either to our website that has a list of resources, or they are provided, again, links based on any feedback that they provide if an individual is interested. And so that does provide, again, recovery centers. It does provide behavioral health providers nearby, and then information on just, again, substance use and misuse resources and handouts that are shared with individuals or, again, redirected to those resources online.
So at the point of distribution, there is not an avenue where they say, I'm ready for help now, that they can actually talk to somebody now. Are they just given a number or the website, and then they have to take the additional initiative of trying to find additional help through those avenues?
So we actually, depending on who's distributing, so if it's our care coordination team, they do provide that navigation. And then some of our other staff who might be already connected to some of those resources also. But if an individual does voice that they do want help, or they want kind of help, further navigation with whoever's distributing, we do have folks that can provide that direct connection and help them through some of that information. So again, some of those programs that do provide it are our communities that care Fountain Valley, which also do a large effort on substance use and misuse prevention. And our other ones are our youth suicide prevention work group, as well as other folks, again, who are equipped to provide, again, that direct navigation if needed. But otherwise, if they don't ask for help, I don't think anybody has at this point, we just provide them with that information and link to resources.
Okay, then I have one additional question. And you mentioned that if somebody wants to purchase Narcan at a pharmacy or whatever, it's about $45. Is there any information on whether providing Narcan at no cost creates a cost displacement such that the $45 in savings can now be used for substances of abuse?
I would have to look into that, but again, from what I've been given from the state, the Narcan naloxone state bowl fund, they have not found any increases in risky behaviors with Narcan distribution for free. And this has been shown in other states that have also distributed Narcan for free, that again, they have not found any increased risky behavior. So I can again provide that research after this to the board.
Okay, this is a different issue than risky behavior. It's a question about cost displacement.
Okay.
Do you have any information about that?
I will have to look into that since this is the first time that's been asked.
Mm-hmm. Thank you.
Thank you.
That's all I have for my director's report. So thank you, Maggie. Appreciate it.
Thank you, everyone. I'll just get you to the end.
Make sure you got all your slides. Good?
A lot of them.
All right, everybody, thank you. Any additional comments from the board? And if not, I will entertain a motion to adjourn with a second.
So moved.
Second.
Thank you. That's Doris makes the motion and General Briggs seconds. All in favor of adjournment, let it be known by saying aye.
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 Okay.
All right, we will see you all next month.